So, chapter 10 is moving us to removing microorganisms from within the body. So, we're going to talk about antimicrobial treatment. If you remember, chapter 9 was all about limiting our exposure to microorganisms by decreasing the number of organisms that are in our environment. So this begins with a little bit of history. The medical revolution in the 1930s with Alexander Fleming's discovery of penicillin as a usable antibiotic, and then the mass production of antibiotics to make them available to the general public. Uh, Antibiotics themselves are common metabolic products of most aerobic bacteria and fungi. In other words, we are extracting chemical components from existing microorganisms and using them to inhibit the growth of other microorganisms. Basically, these are chemicals that are produced as microbial antagonists. Remember, we talked a lot about how in microbial antagonism, organisms will fight for their space, fight for their area within the body that they are using as their normal habitat. Okay? Now, antimicrobial drugs have greatly reduced the incidence of certain infections, but they haven't gotten rid of infectious disease altogether, and they probably never will. The reality is that most organisms will eventually find a way around an antibiotic. Now, we are dangerously close to a post-antibiotic era. A lot of textbooks say this. The reality is that in 2014, the World Health Organization sent out a memo saying the post-antibiotic era is here. We have a lot of drugs that do not work against certain types of microorganisms. So expect in the next few decades to see a lot of resistant infections sort of creeping up in numbers. Now, the overall goal of antimicrobial therapy is to destroy the infective agent without doing any harm to the host. We're going to refer to this as selective toxicity. Organisms that are selectively toxic, or I'm sorry, drugs that are selectively toxic, target the difference between ourselves, in other words, the host, and the microorganism. So keep in mind big differences between prokaryotes and eukaryotes as we move through this. Now, your characteristics of an ideal antimicrobial look a lot like the characteristics of an ideal disinfectant or sterilant. Again, selectively toxic, non-toxic to host cells, so it works on the microorganism but not on us. Our preference is for this to be microbicidal rather than microbistatic. In other words, it kills as opposed to inhibiting. A lot of these actually have to do with maintaining appropriate amounts of the antibiotic within your system for an extended period of time. So functions even when highly diluted in bodily fluids or isn't broken down or excreted prematurely. Organisms cannot become resistant to it. That would be great. Complementing the host defenses. Again, remaining active in tissues and bodily fluids so it's not broken down or deactivated in some way. Gets to where you need it, so it's readily delivered to the site of infection. The cost always comes in somewhere. And doesn't disrupt the host's health by causing allergies or predisposing you to other infections. Now, these sound very similar to a lot of the characteristics of an ideal disinfectant. The reality is, just like the ideal disinfectant, this one doesn't exist, because if it did, it would work on everything. It would kill bacteria, never harm us, and it would be reasonably priced. We'd all have access to it. So we sort of do the best we can with what we have right now. Now, a little bit of terminology just you need to make sure you're familiar with. Chemotherapeutic drug, do not be fooled by this. It is not specific to any type of cancer treatment. Chemotherapeutic agents are any chemical used to treat or relieve symptoms of a disease or disorder. Chemicals that are used prophylactically are used preventatively, basically before you get sick. We give prophylactic antibiotics to surgery patients sometimes just to make sure that they don't get an infection. Antimicrobial chemotherapy is specific to controlling infection. Okay? Antibiotics, again, those natural metabolic products of some microorganisms that are used to inhibit the growth of other microorganisms. Uh, the reality is a lot of the antibiotics on the market are not strict natural products. Most of them have been chemically modified by drug companies, making them semi-synthetic drugs. There are a few out there, and I'll mention them specifically when we get to them. I'll help you make note of them, that are what we consider synthetic drugs that are produced entirely within a lab. In other words, chemical reactions were used to produce this drug. It has no natural source. Most importantly, we see here narrow spectrum and broad spectrum antibiotics. Your narrow spectrum or limited spectrum antibiotics will work on a limited number of microorganisms. In other words, if it only works on the gram-negative organisms, it would be narrow spectrum. Broad spectrum antibiotics are effective against several different types of organisms. They're also known as extended spectrum. You can use them on gram-positives, gram-negatives, maybe some mycobacterium. So if it has several types of bacteria that it works on, it's considered broad spectrum. Now, if you look at this next slide, okay, you can see the spectrum of activity for certain drugs. Polymyxins and how they work make them a very limited spectrum, so narrow spectrum antibiotic. The one that I feel like you should sort of know is tetracyclines. Eventually we'll talk about the tetracyclines. These have the broadest spectrum of activity, and the tetracyclines have a very broad spectrum because of how they work. If you look, they're working on gram-negatives, gram-positives, chlamydias, rickettsias. So 4 of the 5 different types of or groups of bacteria that are listed here. The penicillins, relatively broad. The carbapenems, also broad. Isoniazid, definitely very narrow, sort of limited to the mycobacterium. Okay. Now, before you begin antimicrobial therapy, there are 3 things that we like to know. The nature of the microorganism. This is usually done through collecting specimens. You send them off to the clinical microbiology lab, and they're analyzed by a technician. Okay? Is it gram-positive? Is it gram-negative? What type of organism is it? Susceptibility testing can also be done there. So there's our second one, testing for susceptibility, or sometimes it's called sensitivity testing. In other words, we would like to know which drugs work on this particular organism. And then your overall medical condition of the patient. Okay? How healthy is this person? Do they have allergies to the drug? We'll go through several of these in the upcoming slides. Now, the reality is doctors very frequently will begin some type of antimicrobial therapy on the basis of an educated guess. Okay? It's an informed decision. We don't send everything for testing. Think about coming into the lab or coming into the doctor's office and having something like strep throat. Chances are your doctor could possibly test you for strep throat. A lot of them don't if you show all the normal symptoms. And then they will prescribe an antibiotic without ever doing any type of susceptibility testing because they know what works to cure strep throat 9 times out of 10. So let's talk a little bit about susceptibility testing. First up here, this is what's called the Kirby-Bauer method for susceptibility testing. Not particularly difficult. You guys could very easily do this. The bacteria in question, so your sample from the patient, is taken and swabbed completely across the plate. So we'll cover the plate in bacteria, so we would have sort of what we call a lawn of growth. It would grow everywhere. Right? And then little filter paper discs are actually laid down on top of the bacteria. These are going to be about the size of a pencil eraser. Okay? And all the filter paper discs are actually labeled with what type of antibiotic they have in them and how much antibiotic is there. You push them into the agar a little bit so that they don't fall off. Flip your plate and incubate it. After the plate is incubated and the bacteria have had a chance to grow, you'll pull the plate out, and what you can see is that these areas, okay, around the disc are clear. Okay? The clear areas are what we call zones of inhibition. Okay? Now, in order to determine if this particular antibiotic will work on this bacteria, it's not just, oh, pick the one with the biggest zone. What we do is measure the diameter, so all the way across your zone of inhibition, and compare it to a set of standards. If you look up here, let me change the color so you guys can see this. Okay. So if you look up here, okay, you'll see enrofloxacin 5 grams with a set of numbers. R under 17 millimeters, S 22 millimeters. The R means resistant. In other words, that particular organism is not susceptible to this drug. It will not work on that organism. And susceptible at 22 millimeters, that's our goal. Okay? We want to use enrofloxacin and actually have it work on this particular organism and inhibit or kill this particular organism. The diameter across the zone of inhibition needs to be 22 millimeters. And if you look here, this is 10, 25. Our total length is about 27 millimeters. So yes, enrofloxacin would definitely work. You can see this one here, chloramphenicol, if we go down to the bottom, has a very sort of limited resistance and susceptibility measure. If it's under 21 millimeters, the organism is resistant. If it's 21 or over, the organism is susceptible. This one's been measured for you. You can see it here, the R. This particular organism is resistant to chloramphenicol. Okay? So this is how the Kirby-Bauer test is done. This is what those lab reports that you would get back would look like. Telling you that the organisms were susceptible to certain drugs, intermediately susceptible, so it was between the resistance and the susceptibility numbers for other drugs, and susceptible to ones that would work. So you would choose one of the drugs that the organism was susceptible to in the Kirby-Bauer test. Okay? Obviously, those resistant organisms, okay, or obviously those drugs that the organism is resistant to. Okay? You would not want to use those particular drugs to help treat your patient. Now, another mechanism of doing this is with what we call a tube dilution test. More sensitive and quantitative than the Kirby-Bauer test itself. What we see is the antimicrobial, so your drug is diluted in cereal tubes of broth. So we will put, you can see it down here. So we would have several tubes. This one happens to be done in a plate. Okay? But here, these are representative of tubes. So we would set up several tubes, put the same amount of bacteria in each tube. Okay? You would obviously leave one tube with no drug and one tube with no bacteria, just to use as your positive and negative controls. And then put varying amounts of drug into each tube. Incubate them and go back and look for growth, basically cloudiness of the tube. What you find is what we call the minimum inhibitory concentration. This is the smallest concentration of the drug you need to actually inhibit the growth of the organism. In other words, this is the least amount you could use. Anything less than this is not going to inhibit growth. Okay? See, we'll say this is grams. 2.0 grams works, 1 gram does not, 0.5 grams obviously doesn't. If 2 grams works, that means 4 will and 8 will, and so will 16. Okay? Now, the minimum inhibitory concentration, so we're saying things like lowest dose or amount you can use, will come into play in calculating what we call the therapeutic index. Now, the therapeutic index, okay, is something that, okay, It is calculated by taking the maximum tolerable dose, or what we call the MTD, okay, and dividing it by the minimum inhibitory concentration. Okay? Obviously, the bigger the number, the safer the choice, because you can choose sort of a target range, like you see right here, okay, somewhere between the toxic dose and the lowest dose you could possibly use. That's the goal. Uh, Drugs that have a therapeutic index with a very small number are a riskier choice. You've got to be extremely accurate when calculating dosages here, because it's very difficult to get below the toxic number but above the minimum inhibitory concentration, what's considered the subtherapeutic number. In other words, the dose that will not work. Okay? So accuracy is going to be very key here. That's one of those reasons why they harp on you during med calc. Now, all of that being said, we know that what happens in the body is not necessarily going to match what happens in the lab. So in vitro activity of a drug, in vitro means on glass, but what we're really saying is what happens in the lab is not necessarily what's correlated with in vivo activity or what happens in the body. Okay? So what happens in the lab isn't always going to match up with what's going to happen in the body. We see antimicrobial treatment fail for a variety of reasons. The drug that was chosen can't diffuse down into the body compartment where you need it. Lots of things will not diffuse into joints or make it to the blood-brain barrier. You get resistant microorganisms in the infection that weren't in your original sample. So maybe the sample was collected poorly, or the organisms have mutated and the resistance is a new, okay, genetic advantage for the organisms. We see antimicrobial antagonism, where more than one drug is used and the drugs interact and actually decrease their effectiveness because of the interaction. People fail to take the drug as prescribed. We see that a lot, especially in people doing things like stopping medications before they've taken their entire dosage, or in infections caused by more than one pathogen, where we see what we call polymicrobial or mixed infections. Lots of times the symptoms don't necessarily go away, or they subside slightly and then sort of rebound because the drug works on one of the organisms but not on the other. So those patient histories we were talking about. Physicians have to take careful histories before prescribing an antibiotic. These will include pre-existing conditions that could possibly influence how well the drug works, things like metabolic conditions, history of allergy to certain drugs. Obviously, you do not want to give someone a drug that they are allergic to. Okay? Underlying liver and kidney disease, because I'm sure you all remember that no matter what, if you put it into your body, it has to be filtered out. That's where your liver and kidneys are going to come in. Infants, the elderly, and pregnant women are all going to be special scenarios because, anybody remember, hopefully in your head you are thinking of an answer to this. These are all cases where the individuals are automatically immunocompromised, so extra precautions should be taken. Okay. Other drugs, again, increasing the toxicity of a drug that's there, or having one drug fail. Okay. We see this frequently in people that take antibiotics and having things like their birth control fail. Okay. Genetic or metabolic abnormalities, again, how the drug is processed is going to be important. We don't want a drug that affects the body because it's processed poorly. Okay. Site of infection and route of administration go hand in hand because the site of infection will usually help determine the route of administration. I always tell people that you usually don't get an eye drop for a respiratory infection. There is a reason for that. Okay? Route of administration and site of infection go hand in hand. Okay? As always, cost will play a role. Okay? I'm going to stop here for the first lecture. Okay? Breaking them up into smaller units. The next one will specifically cover mechanisms of action of antimicrobials.